Hi, everyone. My name is Dr. Jeff Stanley, Medical Director at Verta Health, and welcome to day 2 of Beyond Telemedicine. In today's session, we're really excited to explore the need and opportunity to redefine chronic disease care. So COVID-19 has clearly been a challenge for nearly everyone, but it's been particularly hard on people living with chronic illness. Evidence shows us that people living with chronic diseases like diabetes or hypertension are at significantly greater risk for complications from COVID. And studies have even shown that they may be as high as 10 times as likely to die if infected. This can honestly be really terrifying for patients. But even prior to COVID-19, the growth in chronic illnesses has been a global disaster. Take diabetes, for example. More than half of US adults, so nearly 120 million people, now have either prediabetes or type 2 diabetes. So this costs our nation more than $400 billion every year, and it just continues to rise. Studies have been shown that there have been no meaningful improvements in population outcomes in recent years, and the epidemic just continues to grow. So in short, what we're doing just isn't working. But for all the havoc created by COVID-19 and the way it's exposed the fragility of our nation's health, it's also created an opportunity for us to rethink how we treat chronic illness and how we become more resilient against future pandemics. To shed some light on these topics, we're really excited to welcome several guest speakers. In this session, you're going to hear from Dr. Andrew Diamond, the Chief Medical Officer of One Medical, Dr. Shantanu Nundy, Chief Medical Officer of Accolade, Dr. Nicholas Cuttress, Director of Project ECHO at Stanford Medicine, Dr. Francine Kaufman, the Chief Medical Officer of Senseonics and former President of the American Diabetes Association, and Dr. Louise Short, Partner at Strategic Benefit Advisors and Brown & Brown. Thank you all for joining, and we hope you really enjoy the session. The path forward for primary care amid the COVID-19 pandemic. How will primary care be impacted by the recent rise of virtual care?
Well, I am very hopeful that primary care will continue to be seen as critically important. I think prior to COVID, there was a growing understanding that high quality primary care, highly accessible primary care was really the linchpin in any solution to ballooning total cost of care. When we think about a $3.7 or maybe $4 trillion a year healthcare expenditure in the United States, where we believe that at least prior to COVID, maybe as much as 30-40% of that was wasteful. It was increasingly understood that primary care would be critical for solving that problem without compromising the quality of care that patients get. Now, in the COVID era, with the growing adoption of telemedicine by entrenched health systems, I do worry a little bit that more traditional continuity-based primary care is overlooked again. But I do think One Medical and other organizations like ours are providing shining examples of how primary care can remain not just relevant, but extremely important. When we think about what puts people at highest risk for complications and death due to COVID, comorbidities like diabetes, heart disease, hypertension, obesity, those are all problems that we have historically relied on primary care to address. And we are, as in the midst of our response to COVID-19, continuing to try to tackle those chronic illnesses head on for our member population. And we're embracing virtual care solutions to help members achieve higher levels of baseline health so that if they do become infected with COVID, they're more likely to be able to recover and even post-COVID, they're ready for the next pandemic.
How is mental health care changing during the COVID-19 pandemic?
Thanks for asking about behavioral health in particular, because on top of all of the illness and death that COVID has wrought is its impact on the mental and behavioral health of the population, really globally, whether it's fear of becoming infected or fear of job loss or actually enduring job loss or the death of a loved one. It has just been an enormous challenge. And so many of our members, so many of our employer partners have been struggling to mitigate the damage to really the collective psyche of Americans and people all over the world. And turning to One Medical and to primary care solutions to address these concerns, we've always thought of management of mental health problems like anxiety and depression as really natural fits within primary care. This is really what any forward-thinking primary care organization is all about, making sure that behavioral and mental health are knitted together with all other aspects of your primary care. And so we've always welcomed our members to come in and talk about their mental health. We proactively screen all of our members for depression before every annual visit. And we are eager to help our members get connected with therapy. We are also offering now access to coaching programs. We have a group visit program that has been extraordinarily successful in helping patients manage anxiety and also depression. And we've moved that group visit program online where members can come in and book appointments with our providers where they're joined by up to 10 or so other members who are going through similar struggles and share progress collectively. And that really leads to a greatly enhanced experience and a much higher likelihood of improvement. So between coaching, group visit programs, access to therapy for some of our employer partners, and then just great primary care with primary care providers who are eager to help manage these problems, we believe that behavioral health is just critically important.
3 promising models for chronic disease care. Do these new models of care provide the opportunity to create personalized care programs for patients who suffer from multiple chronic conditions?
What we've seen generally through COVID, right, is that it's been a massive accelerator of digital health. And I think so much of that attention has been focused on the idea that rather than seeing your doctor one-on-one in person in a clinic, you can now see your doctor one-on-one online. And while that's an important step towards innovation, the kinds of innovation that I see that my patients need, particularly around chronic conditions like diabetes, is much more than that. They don't just need the visit to their doctor to be more accessible. They need an entire, care system that's built around them. Yes, including virtual, but certainly including other things as well. So the 3 models that I've been really excited about. So the first is the idea of self-service. Today in healthcare, pretty much everything that we need, you have to first go to the doctor for, right? If you want to test for diabetes, you have to first go to a doctor. If you want a medication for diabetes, you got to first go to the doctor. Even if you need a refill of your test strips, you got to go to the doctor. And so the first sort of big model is that idea of self-service, as how can we help people make those decisions and take those first few steps themselves? Because so many people don't have a doctor or can't access one. And so if everything relies on that, we're actually creating a massive bottleneck in people's care. So that's the first. The second is the idea of really creating a connected healthcare experience around the member, around the patient, right? The idea that we live and die by any chronic condition like diabetes from the behaviors we do every day. The second model, which I've been really interested in, which is the idea of leveraging people's mobile phones to create a system that's sending them, daily reminders and providing them what's called exception-based care, so that you're being able to proactively react to changes in their health conditions rather than simply waiting for that next visit, which is 3 months down the road. And then the third model is this idea of one-to-many care, right? The idea that today, we have a shortage in many respects of doctors, and that so many of the solutions we talk about in healthcare are simply throwing more doctors or more healthcare providers to the problem. But one way to get much more leverage in that is to move to that exception-based model where you have a single provider who's able to look at data across a population of people and not just simply have visits with everybody, every 3 months or have phone calls with everybody every week, but to use that data to understand who really needs that care And in that way, you're actually simultaneously getting more care to the people that really need it, while also being able to decrease the sort of not needed check-ins for people that don't need it. And so you're actually able to get a lot more leverage and provide much more intensive support to a large group of people, while also managing the limited resource we have around healthcare professionals. I think core to I think all three models really is that idea of personalization. I think, and personalization is multidimensional, right? So one is that people should be able to choose how they want to be cared for, right? And so what I mean by that is right now, we all sort of have a one-size-fits-all model, which is, everyone needs to come to a clinic, everyone needs to see a doctor, and everyone needs to see that doctor, 2 or 3 times or 4 times a year. At the same time, we don't want to go the other direction, right? I think a lot of the pushback we have in the technology community when we talk about these new innovations that I talked about earlier is the idea of, well, that's not going to work for everybody. Older patients, they want to be seen, and people don't have connectivity, people don't have phones. And so really what we need is that first level of personalization around how do you want to be cared for, right? And you can decide, you should be given a menu of different delivery models, and you should be able to choose, and that neither one extreme or the other, one size fits all, is the right answer. So that's the first level of personalization. The second level of personalization is that you should be able to have some agency around the care team that you wrap around yourself, right? People have a broad range of needs and preferences. And I think we focus a lot on needs, particularly biomedical needs in healthcare, but we don't talk enough about social needs, and we definitely don't talk about people's preferences, right? I talk about my mom who has type 2 diabetes. She is an immigrant from India. She's vegetarian and she prefers Indian food. And she prefers seeing doctors who are Indian or from that area, or at least who understand the cultural preferences that she has. And then the third level of personalization comes to the individual sort of day-to-day care, right? And that's that idea that, people should get care sort of when and where they need it. And that requires us to tailor their care day to day to their needs. And that means we're going to need data to understand where people are sort of, if not every day, certainly every week, right? So an example I gave around my mother is actually that, she is part of the Verda program, and around the birth of her 4th grandchild, she went to Seattle. And the team at Verda was able to understand that transition was happening, that my mom was flying across country, that she'd be on a new time zone, have to have a new routine, and was able to personalize her care at that third level so that she got adjustments to her medication regimen, adjustments to her diet regimen and recommendations that really helped accommodate her. Too often we have patients fit their lives into care, not figure out a way to fit our care into their lives. And so that's really the third level of personalization we really urgently need. I think that COVID-19 has been an incredible accelerator, right? I think there's been a lot of attention to that fact that, we're 7 to 10 years ahead of where we were just this past January, and that's amazing. But I also want to make the point that we have a long way to go, that simply taking care that's brick and mortar and one-on-one and in person and flipping that to a virtual model isn't enough. We have an absolute opportunity here. This is a catalytic moment, on the back of a horrendous tragedy to really reinvent a whole new healthcare system. And I think we all need to have a much more sort of holistic, inclusive conversation around where we need to go. Simply putting sort of telemedicine isn't going to be the answer, and certainly not reverting to the care we had before. There's a middle way, and that's the direction that we need to work together toward and figure out that way forward.
Case studies on virtual models of chronic disease care. How has the COVID-19 pandemic impacted mental health and well-being? How can employers address their employees' needs during this critical time?
There really was a behavioral health pandemic in this country before COVID-19. The estimates before COVID were that 1 out of every 2 American adults would have some kind of a behavioral health issue in their lifetime, issue/diagnosis, which is huge. When you think about, there's no other sort of disease category where 1 out of 2 people are affected in this country. So the BH pandemic was here before COVID, and it's going to last, in my mind, a lot longer than the COVID-19 pandemic. And it really has caused financial, social, emotional, and physical stress, hitting every pillar of well-being. And as you see on this slide, 70% of Americans are concerned about the economy, 67% are stressed by the government's response, and almost 20% of Americans have a physical response when thinking about the pandemic. People are calling hotlines for help, and anxiety and depression are increasing. Many employers and their HR staff are aware of the 4 p.m. Friday crisis when someone has an acute behavioral health need. They're experiencing substance abuse or depression, suicidal, and no one knows where to start to help someone in crisis. And the entry points to the system often are not clear and not easily accessible. And even employers that offer a variety of resources, such as the ones on this slide, including EAP, BH Telemed, CBT, Resilience Solutions, they may not have clear pathways for people to enter the system and engage where and when they need services. And I can tell you just from my own perspective, because I wear 2 hats. One is as a consultant to our employer clients, but the other is working with our own HR staff and our teammates. We actually changed our internal landing page so that our company landing page has a big red box that says, do you need to de-stress? And then it just has a click to the EAP. And so previously it wasn't easy to find or connect with the EAP. So it's really, really important from a communications perspective that everything is understandable to people. But, my advice, if we move on to the next slide, is always that employers should look at strategy first. So start with your goals, your data, and address 5 areas that are key to having a comprehensive behavioral health approach. And these include access and quality of care, integration, as we just spoke about, and navigation of benefits and healthcare services. So what we've seen is some employers are using mental health first aid, which is kind of like CPR, but on the mental health side. And it's a program where you can train HR, leadership, management to really focus on mental health, understand signs and symptoms, teach them how to talk to people. They're not going to be therapists, but to identify when people are having a problem and refer them to the right resources. And some employers have even taken it a step further with mental health ally networks that are somewhat like wellness champion networks, but really focused on behavioral health.
How can employers make the most immediate impact right now in behavioral health?
Yep. So I think that that's really an important question. And what I would say is leverage what you can and what you already have in place. A lot of vendors now have free information or free resources. But if you have an EAP or health vendors or other kinds of relationships, they generally will have resources and communications. And so even if you have things, start promoting them. So I gave the example of how we've promoted our own EAP. Try to eliminate the stigma about getting help, about things that people are struggling with, and try to kind of elevate, if you can, and let people know that other people are struggling with the same types of issues, because that often is very helpful. And then as far as supporting return to the workplace, really important. People are going to have a lot of anxiety returning to the workplace. So providing communication about the workplace, about how it's being how the return to the workplace is being structured, trainings on adjustment back to the workplace, information about safety and how you're keeping employees safe and the measures you're putting in, whether it's masks or social distancing or rearranging the workspaces, putting up barriers. All of that's really important to reassure people and to make sure that your managers know to lead with empathy and to help them with some trainings and just encourage them to listen. Other things that we've seen employers do are provide resources for childcare, elder care, which are really, really critical at this time. And then I would say there are industry-specific needs. For example, healthcare, maybe workers are dealing with a whole host of different issues that may create a lot of anxiety and stress. So, look at your own workplace and your own industry and figure out, how you can aim your interventions to be very specific to your workforce.
America's type 2 diabetes epidemic and how virtual care enables diabetes reversal. How is type 2 diabetes traditionally managed? How does diabetes reversal differ?
This has already been gone over, but I think the bottom bullet maybe is the most important. First of all, I like to say I'm old and I'm really quite proud of it. And I've had an over 40-year career already in diabetes, in active patient care, in both clinical, basic, and actually public health research. This led me in 2003 to be the president of the American Diabetes Association, and just really a great opportunity to see the impact of what diabetes has on not only individuals, but actually on our entire healthcare system as well as our society. So let me start with this slide. It is my favorite slide ever. And it kind of goes through the epidemic of diabetes. You know, the word epidemic now has quite a different meaning, but this has been labeled an epidemic for a number of decades already. But as a chronic disease itself, diabetes has been something that I think we can all appreciate has really stressed not only the populace, the healthcare system, but all of society. So there are at least 30 million Americans now in the United States with diabetes, a tremendous amount of money spent in prescription medications as a result of that diagnosis, and the overall cost huge of over $400 billion in the United States. You know, this would be true for my own patient, although because of her age, it was a little bit more accelerated, but an adult who usually gets the diagnosis of type 2 starts on an oral generic medication. This is part of the standards of care from the American Diabetes Association. And then we wait till they fail. Their glucose levels have elevated, their A1C, the marker of control, has deteriorated, and then we add another branded now oral medication that is quite expensive on a year-term basis, and then we wait till that fails. And then we add another branded injectable at that point in time, and now the overall course of the A1C is higher and higher, and then we add insulin, and then we add aggressive insulin therapy, and all the while not actually being able to control the patient, now spending over $10,000 per patient per year to give pharmacotherapy that is not ameliorating the disease. Whereas if we go to a program that's really continuous, intensive, getting them to be able to reverse some of the aspects of the obesity, of the dietary issues involved with the promotion of the diabetogenic phenotype, then we can start to reduce insulin. We can start to de-prescript this patient and take away some of the other very expensive branded medications, and maybe have the opportunity to get them off all medications. And at the same time, achieve the kind of glucose outcomes that will enable that patient to have a healthy future. So if we look at it this way, we can kind of see the management of diabetes. I'm like climbing a mountain, adding and adding and adding to that backpack on my patient of medication and cost and burden. And what I want to do now is not only stay at the top of that mountain, I want to come back down to level ground by de-escalating their medications, by improving their outcome, by getting them the support, the programs, the individualization for them that will make this possible. And what's really the compelling reason is that this is what happens in a day in the United States as a result of diabetes. Thousands of people diagnosed every day, and hundreds of people dying. Across the board, foot ulcers in a multitude of patients that leads to, on a daily rate, an amputation of a toe or another toe or of a foot. Spending billions of dollars having thousands, tens of thousands of hospitalizations, watching patients go into end-stage renal failure, and yet giving multiple medications for the patient. By the time the patient has had 10 or 15 or 20 years of diabetes, they may well be on 9 or more medications to treat glucose, blood pressure, lipids, depression, erectile dysfunction, you name it. And all of that just keeps adding and adding, where we have the ability now, when supported, when done correctly, to de-escalate this disease and even get to the point of reversing it. So kind of in conclusion, I don't think I have to convince any of you that there's been a significant rise in diabetes, and the strategies we have had in the past haven't really worked. We've continued to watch patients get diagnosed and not get to the kind of management that will enable them, if they get a COVID infection, to weather it, or if they don't and live another 10 or 20. My patient has already had a decade and a half of diabetes burden. So we need to be able to reverse this disease in a very comprehensive program that gives multiple levels of care, touch points, continuous, using every available platform that there is. Lots of programs out there layered on top so that the patient can improve self-efficacy and improve their own outcomes. So I ask you, for my own patient, at this point, 28, now employed, really at the beginning of her adult life, doing better than she's ever done before, what really is her future? And how will I give her care, or the next set of providers, since at some point, since I am a pediatric endocrinologist, she's going to have to go to an adult center soon. But what will that center be able to offer her? And I can tell you that in the future, it needs to be something that's comprehensive and something that's continuous, utilizing all of these platforms so that she can live a long and healthy life.
Project ECHO, an innovative model to augment the primary care workforce to enhance quality and increase access to diabetes care.
So the goal of Project ECHO is to empower and increase the capacity of primary care providers to address the needs of patients with insulin-requiring diabetes who do not have access to routine specialty care. And even before COVID-19, there was system failure for people living with diabetes. And so for health plans who report HEDIS data, you see that only less than a third of patients with type 1 and type 2 diabetes meet A1C targets of less than 7%. Perhaps even more concerning is the kind of A1C poor control, or A1C of greater than 9%, where in the Medicaid HMO population nationally, it's over 40%, and that's double what it is of the Medicare population. So very vulnerable populations seeing worse outcomes than others. We're all probably very aware of the shortage of endocrinologists, that there just are not enough endocrinologists to see patients with diabetes. And the reality is that there are more primary care providers positioned to take care of people with diabetes. And barriers to care, there's financial barriers to care. So for low-income children and families taking time off work to go to a specialty center and waiting in line, seeing a provider and asking to do that several times a year, that's a big ask when they might take off work and lose income. And then there's the supply-demand mismatch in terms of lack of specialists. And then rural, asking people to drive 5 or 6 hours to come to a specialty care clinic and be able to afford to fill up a gas or even have a car to go that distance, and then trying to find money to spend the night if you live that far. Project ECHO was started to try to move the knowledge to primary care providers instead of moving patients, and trying to amplify knowledge. And so ECHO is a all-teach, all-learn model. It's different than traditional telemedicine, where I practice telemedicine in my practice, but there's still not enough of me, of specialists, to see all the patients. And so it's targeting primary care providers and trying to amplify the knowledge. And so what are benefits to clinics or spoke sites who participate? So there's a weekly hour-long telementoring clinic. Usually we have one champion, but it's open to as many participants from the clinic as possible. They have access to real-time support from spoke sites, and the spokes have real-time access to the hubs on the off hours. And what do we learn from our pilot for type 1 diabetes? Initially, there was a thought, well, type 1 diabetes is such a small percent of diabetes, and primary care providers aren't managing it. So what we found out that PCPs lack confidence in type 1 management, and particularly in insulin management and diabetes technology. Prior to starting, we did a needs assessment and we surveyed primary care providers throughout the states of California and Florida. We found out in the adult population, over 70% of PCPs were prescribing insulin for type 1 diabetes. And in pediatrics, about over 1/3 were prescribing insulin. So even though patients might have access to an endocrinologist like myself, the burden of management and touch points are falling on primary care providers, and they aren't confident in insulin dose management and particularly diabetes technology as well. They don't have care protocols for managing type 1 diabetes in their clinic, and they were interested in learning more. We conducted focus groups of patients with type 1 diabetes who lack routine access to specialty care to better understand barriers to care and needs. And they reported they wanted more empathetic physicians, and lots of them didn't like seeing their endocrinologists because they felt that they weren't empathetic, and they preferred to rely on their primary care provider. They also expressed this need for more social support and feeling isolated. So after we piloted the type 1 echo, we've now expanded echo diabetes to insulin requiring type 2. And our goal is really trying to not just expand this within the states of California and Florida, but make it easier for other states and multiple programs within a state to start echo programs for diabetes and be a training center in terms of supporting those.
Thanks again for joining, and thanks to the panelists. We heard a number of really interesting insights in the session. You heard many of the panelists paint a grim but unfortunately accurate picture of the state of chronic disease in the US. It really underscores the need to think differently about how we create solutions to these difficult problems. We also heard not just hope, but also some guidance for change. Excellent primary care can play a significant role in this change, especially if we refocus on preventative services. And when we're contemplating care models, we need to think beyond just flipping brick and mortar care to virtual care and consider systems that are designed for and around patients. This can account for a broad range of needs and preferences and help to truly deliver transformative care.